The nurse did not see a future chief of medicine when she looked at the black woman in the emergency room. She saw an inconvenience, an exaggeration, a problem to move out of the way. It was a winter evening when Angela Harris arrived at the hospital. The air outside carried the kind of cold that bites through coats and settles in the bones. Inside the emergency department, the air was bright, sterile, and tired. Monitors beeped, phones rang, wheels squeaked across linoleum floors. In the middle of it all, the waiting room sat full, like a held breath. Angela pressed a hand against her side as she sat in a plastic chair. Pain ran under her ribs like a burning wire, sharp and deep. It had started the night before as a tightness in her upper abdomen and chest, something she had tried to ignore. But by evening, it had become so intense that she could not stand upright. Her daughter had insisted on driving her to the hospital. Angela was not the kind of person who rushed to emergency rooms. She had worked for years as a nurse's aide in a small clinic. She understood triage. She understood that some people needed immediate attention while others waited. She did not demand miracles. She simply wanted to know what was happening inside her body and whether it was about to kill her. She checked in at the front desk, gave her name, her age, her symptoms. The clerk entered everything into a computer and handed her a band with her information. Angela wrapped it around her wrist and took her place among the other patients. Time moved slowly. An hour passed, then another. The pain did not calm down. It grew heavier, like a hand squeezing from the inside. Angela shifted in her chair, breathing shallowly, trying to find any position that gave relief. Sweat broke out along her hairline, even though the room was cool. Eventually, a nurse in light blue scrubs called her name. Angela stood carefully and followed her down a hallway into a curtained area. The nurse moved with quick, practiced motions. Her name badge hung from her pocket. Angela noticed the way the woman's eyes flicked over her. Age, race, body size, clothing. It was a familiar glance. Angela had seen it many times directed at other black patients. The nurse asked questions about the pain, its location, its timing. Angela answered as clearly as she could. She explained that she had no history of heart problems, that she took her blood pressure medication regularly, that she had felt fine 2 days earlier. She admitted that she had thought about ignoring it, but the pain had become so strong she could no longer sleep. The nurse recorded the information, took her vital signs, and listened to her chest with a stethoscope. Her face remained neutral, but the tone of her voice shifted in ways Angela recognized too well. The nurse suggested that anxiety might be contributing. She mentioned stress, diet, and the possibility of indigestion. She did not mention anything more serious. She did not order an immediate electrocardiogram. She did not call a doctor in. Angela tried to explain that she knew her own body, that this pain felt different from anything she had experienced before. She spoke calmly, but beneath her words lay fear. She thought of her mother, who had died young after doctors brushed off her early symptoms. She thought of articles she had read about how often black patients' pain was underestimated or dismissed. The nurse noted her comments, but her posture carried impatience. She suggested that Angela was overestimating the intensity of the pain, that people often worried when it was not necessary. She placed the blame quietly back into Angela's hands. Perhaps, she implied, this was an overreaction. The next step should have been simple. A standard protocol for chest or upper abdominal pain would have included tests to rule out serious conditions. But that evening, in that crowded emergency department, the nurse made a different choice. She marked Angela's case as low priority. She directed her back to the waiting area with instructions to sit and relax. She promised that someone would see her eventually. Angela returned to her plastic chair, moving more slowly now. The pain continued to flare and ebb, like an angry tide. Hours dragged by. A television mounted on the wall played news and weather, then late-night talk shows. People came and went. No one called her back. Sometime after midnight, exhausted and discouraged, Angela made a decision. She did not feel that anyone in this place believed her. She had seen the nurse's expression, heard the tone that suggested she was simply anxious. The idea of collapsing in a lobby full of strangers frightened her. She convinced herself that perhaps this would pass. She signed a form acknowledging that she was leaving on her own, and her daughter drove her home. The pain eventually eased enough for her to sleep, but over the next months, it returned in smaller waves. Her primary care doctor, who knew her well and listened carefully, ordered tests and referrals. The diagnosis came slowly, in steps. Underneath Angela's ribs, where the first hospital saw nothing urgent, a serious condition had been developing. It was not immediately fatal, but it required real treatment and long-term attention. Angela followed every instruction she was given. She adjusted her medication, changed her routines, attended appointments. She also carried something else inside her now, a persistent memory of being invisible in a place where she was supposed to be safe. That memory settled beside her diagnosis and refused to leave. Years passed. Angela's health stabilized. She continued to work, first as a nurse's aide, then as a nurse after returning to school in her 40s. She studied in the evenings, reading textbooks at her kitchen table with her blood pressure cuff nearby. She learned not only the science of medicine, but also the long, difficult history of how Black patients had been treated in hospitals and clinics. Her instructors emphasized protocols. Her textbooks emphasized standards of care. But Angela knew that what happened in real rooms often looked different from what was written on the page. She had lived that difference, sitting in a chair with her wristband on, listening to a nurse suggest that her pain was an exaggeration. Angela finished her nursing degree, then pursued further training. She discovered a talent for internal medicine and a deep interest in how systems could be improved. While other students dreamed of private practice, she felt drawn to hospital medicine, policy, and administration. Over time, she became Dr. Angela Harris. The title did not erase her memories. Instead, it sharpened them. As she moved through halls in white coats instead of scrub tops, she paid attention to how staff spoke to patients, who received extra tests, and who was sent home with vague instructions, whose concerns were taken seriously and whose were brushed aside. She joined committees focused on quality and safety. She volunteered for working groups examining health disparities. She read research that confirmed what she had already sensed. Black patients often received less pain medication, fewer referrals, and slower interventions. The patterns were not theoretical. They were woven into real lives and real outcomes. Her career grew. She became known as a physician who listened carefully, explained clearly, and advocated quietly, but relentlessly. When positions opened in leadership, her name began to appear on lists. She never forgot the night when a different nurse in a different role had decided that her suffering was not urgent. Then, after many years, a familiar institution entered her life again. The hospital that had once turned her away needed a new chief of medicine. The role was demanding. It involved shaping clinical standards, overseeing protocols, and guiding the culture of care. A search committee was formed. Community members were invited to contribute perspectives. By then, Angela had been working at another hospital in the same city, leading a division and building a reputation for reducing readmission rates and closing gaps in care. When someone suggested her name to the committee, it did not feel like a charity gesture. It felt appropriate. Her experience, her calm leadership, and her ability to bridge clinical work with human understanding made her a strong candidate. She submitted a formal application. During the interview process, she spoke clearly about her vision. She described hospitals not just as buildings full of machines, but as places where patterns of respect or neglect shaped outcomes as much as medications did. She talked about the need for better training in bias, improved communication, and data that did not bury uncomfortable truths. She did not mention her own night in that waiting room at first. She focused on systems instead of wounds. But in one final conversation with the board, when asked why this particular hospital mattered to her, she decided to tell the story from beginning to end. She described a winter evening, a painful walk down a hallway, a dismissive assessment, and a quiet departure. Names had changed. Staff had turned over. But the lesson remained. The board listened. Some members shifted in their seats as they recognized the institution's reflection in her story. It was not a flattering image. It was, however, an honest one. Weeks later, the announcement went out. Dr. Angela Harris would become the new chief of medicine at the same hospital where Angela the patient had once been told without words that her pain did not count. On her first day in the role, Angela walked through the emergency department with a different badge and a different authority. The automatic doors opened with the same soft hiss. The waiting room still held a mixture of fear, boredom, and hope. Families still sat in chairs, holding coats and plastic bags, waiting for their names to be called. She did not arrive with a desire to punish. She arrived with a plan. Under her guidance, the hospital began to change. Some changes were visible. New trainings appeared on the staff schedule, not as optional seminars, but as required education. These sessions focused on the history of racial bias in medicine, on listening to patients, and on standardizing care so that personal assumptions played less of a role. Other changes lived inside policies. Triage protocols were rewritten to ensure that reports of pain and certain risk factors triggered specific actions, regardless of who reported them. Data dashboards were updated to display outcomes by race and other demographics, making disparities impossible to ignore. Performance reviews began to include measures related to patient experience, not just efficiency. Angela also created a small internal group that met regularly to review cases where patients felt unheard or dismissed. The group included nurses, physicians, social workers, and community representatives. They did not meet to assign blame, but to understand patterns and prevent repetition. Sometimes they invited staff involved in those cases to listen and learn. Over time, the tone of these meetings changed from defensive to reflective. People began to behave differently. Some staff resisted at first, rolling their eyes at new requirements or quietly complaining. Others felt relief, having long noticed problems they did not know how to address. A younger nurse later admitted that hearing about Angela's past experience in the same building had changed the way she approached patients who reminded her of that younger version of Angela. In the emergency department, the triage area gained a new quiet discipline. Nurses still made rapid assessments, but the language they used shifted. Instead of describing Black patients as overreacting or dramatic, they started to describe symptoms with more neutral, precise terms. They ordered tests when protocols indicated, rather than when their personal comfort levels allowed. None of this made the hospital perfect. Mistakes still happened. Bias did not vanish overnight. But the direction of movement changed. The institution began to look itself in the mirror more often, and with fewer excuses. Sometimes, late in the evening, Angela would stand at the edge of the waiting room and simply watch. People did not recognize her there. She blended in with visitors in a simple coat, hands folded in front of her. She listened to the tone of the staff, watched who was called back and how quickly. When she saw something that concerned her, she made a note for a later conversation. When she saw a nurse kneel to speak to an elderly patient at eye level, or a doctor take an extra minute to explain a test to a scared family, she made a different kind of note. The memory of that first night never left her. She remembered the pain, the humiliation, the feeling of being pushed aside. But with time, the sharpness softened into something else, a source of direction. That experience became one of many reasons she pushed for change, not out of bitterness, but out of determination that fewer people would sit in that same fear without being heard. The nurse who once dismissed her pain had long since moved on by the time Angela took over as chief of medicine. The story was not about catching one person and punishing her. It was about understanding how easy it is for professionals to absorb dangerous assumptions and turn them into decisions. It was about building a system where those assumptions were less likely to go unchallenged. Angela knew that not every patient would become a doctor or a leader. Most would leave the hospital and never see its inner workings. They would not sit in committee meetings or help write protocols. They would only remember how they were treated when they came in, vulnerable and afraid. For that reason, she returned again and again to a simple idea. Behind every chart and wristband sat a full human life. Behind every complaint of pain sat a story. Many of those stories belonged to people who had been told for generations that their suffering did not matter. The nurse once ignored a black patient's pain. Years later, the hospital had to face that same woman as its chief of medicine. The building did not change overnight, but step by step, policy by policy, conversation by conversation, it moved closer to being a place where fewer people would walk out feeling invisible. In the grand scheme of things, it was one hospital in one city. To the people who sat in its chairs and lay in its beds, those changes could mean the difference between neglect and care, between fear and trust, and sometimes between life and death.